Welcome. Today, we're focusing on a serious complication of sickle cell diseases, sickle cell disease, related pulmonary hypertension, or SCD-PH. We'll explore what it is, why it happens, and what can be done about it. The primary cause of SCD-PH is, of course, sickle cell disease itself. The abnormal sickle-shaped red blood cells characteristic of the disease lead to chronic hemolysis, the breakdown of red blood cells. This hemolysis releases substances that damage the lining of the blood vessels in the lungs, increasing pulmonary vascular resistance and contributing to the development of pulmonary hypertension. Other contributing factors can include chronic thromboembolic disease from recurrent vaso-occlusive crises, left ventricular diastolic dysfunction, and sleep-disordered breathing. Now, let's delve into the pathophysiology. The chronic hemolysis triggers a cascade of events. Damaged red blood cells release free hemoglobin, which scavenges nitric oxide, a crucial vasodilator. This reduction in nitric oxide availability causes vasoconstriction in the pulmonary arteries. At the same time, hemolysis activates platelets and the coagulation cascade, increasing the risk of pulmonary thrombosis. The chronic inflammation and hypoxia caused by sickle cell crises further contribute to the remodeling of the pulmonary arteries, leading to increased pulmonary vascular resistance and ultimately, pulmonary hypertension. Bone marrow hyperplasia in sickle cell disease can lead to increased endothelin-1 production, which is another potent vasoconstrictor. All of these factors work together to significantly elevate pressure within the pulmonary arteries. SCD-PH is a significant health concern for individuals with sickle cell disease. Studies suggest that its prevalence ranges from 6 to 11% in adults with SCD, though some estimates go higher depending on the criteria used. This complication is more commonly observed in adults than children with sickle cell disease and is associated with increased morbidity and mortality. The presence of pulmonary hypertension in individuals with SCD often signals a more severe disease course. The signs and symptoms of SCD-PH can be subtle and often mimic other complications of sickle cell disease. Common symptoms include shortness of breath, especially during exertion, fatigue, chest pain, dizziness or lightheadedness, and swelling in the ankles, legs, or abdomen. In more severe cases, patients may experience fainting spells or cyanosis, a bluish discoloration of the skin, indicating low oxygen levels in the blood. Because these symptoms can be easily attributed to other conditions, SCD-PH is often underdiagnosed. Diagnosing SCD-PH requires a comprehensive evaluation. The initial step is usually an echocardiogram, which can estimate the pulmonary artery pressure. If the echocardiogram suggests pulmonary hypertension, a right heart catheterization is necessary to confirm the diagnosis and measure the pulmonary artery pressures directly. This procedure is the gold standard for diagnosing pulmonary hypertension. Other tests, such as pulmonary function tests, ventilation, perfusion scans, and CT scans of the chest, may be used to rule out other potential causes of the patient's symptoms and assess the overall lung health. While pulmonary hypertension has a classification system, SCD-PH is specifically Group 5 pulmonary hypertension, associated with hematologic disorders. However, within SCD-PH, there are not distinct types, but rather varying degrees of severity and different underlying mechanisms contributing to the condition, like hemolysis, related thromboembolic, or left heart dysfunction related. Management of SCD-PH is complex and requires a multidisciplinary approach. The primary goals of treatment are to reduce pulmonary artery pressure, improve exercise capacity, and prolong survival. Treatment strategies may include pulmonary hypertension, specific medications, such as phosphodiesterase 5 inhibitors, endothelin receptor antagonists, and prostacyclin analogs, management of underlying sickle cell disease with hydroxyurea or chronic transfusion therapy to reduce hemolysis and vaso-occlusive crises, anticoagulation prevent pulmonary thrombosis, oxygen therapy to improve oxygen saturation, and supportive care to manage symptoms and complications. For severe cases, lung transplantation may be considered, but this is a complex and high-risk option. Currently, there is no specific way to completely prevent SCD-PH in individuals with sickle cell disease. However, early diagnosis and proactive management of sickle cell disease can help to reduce the risk. Regular monitoring of pulmonary artery pressure with echocardiography, especially in individuals with risk factors such as frequent vaso-occlusive crises or a history of acute chest syndrome, is crucial. Optimizing sickle cell disease management with hydroxyurea, chronic transfusion therapy, and prompt treatment of complications can also help to mitigate the risk of developing pulmonary hypertension. The prognosis of SCD-PH varies depending on the severity of the condition and the individual's response to treatment. Unfortunately, SCD-PH is associated with a poorer prognosis compared to pulmonary hypertension from other causes. However, with early diagnosis, aggressive management, and advances in pulmonary hypertension, specific therapies, it is possible to improve outcomes and prolong survival. Ongoing research is focused on identifying new targets for treatment and developing more effective strategies for preventing and managing SCD-PH. Recent studies are exploring the role of novel therapies that target specific pathways involved in the pathogenesis of SCD-PH, such as the nitric oxide pathway and the endothelin pathway. Further research is needed to fully understand the complex mechanisms underlying SCD-PH and to develop more effective and targeted therapies.